You aren't playing with it, are you? Because you can get in big trouble if you don't know what you're doing.
Department Director of Unit 5500 at Cone Health. And I'm Lindsay Draper, the Assistant Director of Department 5500. We're so excited to share with you our Magnet Journey to Redesignation. And we're here to show you glimpses of what our unit has achieved through the year. We wanted to show you the model of care that we deliver with caring, competence, and celebration. You'll see a little pieces of humor, but we wanted to let you know that the ultimate outcome is doing what's right for the patient. We are here to show you everything that we've worked on throughout the past year. Now, while some of the actions in the video may seem a little bit silly, please keep in mind that they are real-life situations that could happen in the hospital. We hope you enjoy our video as we strive for the best possible outcomes for our patients.
So here in 5500, for the past 6 months, we've been doing what we call multidisciplinary rounds, which basically involves the attending physician along with the bedside nurse, the charge nurse, the case management worker, the social worker, pharmacist, and at times the physical therapist. We basically, discuss about the patient in general, plan of care, major events that happen overnight, major issues. If there's a significant family issue, we talk about family dynamics. We also try and practice evidence-based medicine during these rounds. Some of these rounds are actually very educational for the nursing staff. We discuss some cases and the appropriate management, the plan of care. We also try and be proactive and try and get the Foley catheter taken out as soon as possible. Make sure patients are on DVT prophylaxis, make sure they don't fall, and make sure they're on appropriate fall precautions. So when we do these rounds, we feel that it's a team effort. All the team members are on one page, and they get a 360-degree view of everything that's going on with the patient, and we believe it provides best patient care.
Alright, we'll make sure we put him on the right medications, adjust his medication. So, in terms of his hospital course, we continue his steroids, we continue his...
We got Mary Smith in room 8. She came in with a DVT. She was a young lady that's had a DVT in the past, and so it looks like she's going to be on some Coumadin or something for that long term.
Yeah, so she's very young. This is the second episode of DVT. This time it's pretty extensive, and it's all the way from the knees down to up to her pelvis actually. So she's going to need extensive teaching with Lovenox and Coumadin, and she's obviously going to need a follow-up appointment to check her INR. So we'll have to get that ball rolling on her, and I don't know if she's going to be able to afford the Lovenox.
I spoke with her yesterday, and she would not be able to afford it, so we're going to help her with medication assistance.
Has anyone considered one of the new anticoagulants for them, like Xarelto?
Yes, but unfortunately, she does not have insurance, so we'll just have to stick with Coumadin in this case, and she's probably going to be on it for lifelong.
You know, every year in hospitals in the United States, somewhere between 700,000 and 1 million patients fall every year in the hospital. Yeah, and so what we do here in 5500 is we try to prevent that. Now, those falls, every time someone falls like this, we have injuries, we have increased hospital stays, we have increased costs of health care. We want to avoid all of those things. So what do? Well, we start with some careful assessment of fall risk. And every patient is different in terms of why they fall. So we want to make sure we assess those reasons carefully, and then we want to implement proven strategies, proven interventions to prevent those falls from ever happening. So we've actually piloted a study this year. It's a new way of assessing fall risk and then choosing interventions based on those fall assessments. And so what we do is figure out what their individual risk factors are, and then we map those risk factors to strategies or to interventions that we think are going to prevent falls in those categories of risk factors. And so we are in the midst of that study even as we're making this video, and results will be coming out soon. So this work we're doing on figuring out better ways to prevent falls basically corresponds to the magnet component called new knowledge and innovation. We're finding better ways to do things. The end. Ooh! How about that?
Okay, go on now.
No, I'm supposed to stay here with you.
Please, I've got this.
I'm supposed to stay with you to make sure that you don't fall.
No.
Okay?
No, I've got it. I can do it. I want to be by myself.
I know, but I'm supposed to
Please,
stay.
just leave.
You have on red socks.
Please, just
and
leave.
I'm supposed to stay here.
Please, go. Go.
Mr. I'm here with you. Can you help? We need some more help. We need to call for more help. Come on, try me up. Come on. I told you I was supposed to stay here with you.
Go on out.
Mr. Austin, I'm not going to leave, but I'll crack the door to stay ready to make sure that you're safe.
Okay.
Is that good enough for you?
That works.
Okay. All right. I'll be right out here outside the door. When you get through, just press that call bell right there. Just pull it down, the green button, the blue button there, pull it in. Okay. You ready? Okay. I'll help you up, okay?
Hi, my name is Shanita Lee. I'm a nurse here at Moses Cone. I've been employed by Cone for 4 years, and I have been in my professional career for 10. Today I'm going to talk to you a little bit about the SBAR reporting tool and how 5500 used it and made it our own. SBAR stands for Situation, Background, Assessment, and Recommendations. SBAR has been proved to be effective and efficient way of communication for shift to shift, and it also offers a simple way to communicate, and it allows staff to have a standardized 5500 took the SBAR form and customized it for our unit. So under structure empowerment, we met with our shared governance team, and one of our very own nurses by the name of Jessie Westlink created an SBAR form. And our shared governance team tweaked it and made it our own and customized it for our unit. It has been proven to be the best practice, and it helps improve patient safety and communication between shifts. So the only difference from this form and our hospital-wide form is just under the assessment section, we kind of broke it up to systems, which you see highlighted. Under new knowledge and innovation, the SBAR tool was found to be best practice for report and Joint Commission for accreditation added standardized communication to one of their patient safety goals. So with that being said, they recommended the SBAR tool, and our wonderful leaders here at Moses Cone saw that it was a need to implement in our healthcare system, and with our goals coming to be the top 10 and becoming the top 10 in the nation, we implemented the SBAR form, which is the standardized form here. And this also helped with our families and the quality care that we provide to our patients and our community.
Mr. McAllister, can we come in?
Mr. McAllister.
Yes. I'm good to leave. I told you, this is Janice. She's going to be your nurse for today. I'm going to give her a report, okay?
Okay.
She's been at Most Come for several years, and she's a good nurse. She's going to take very good care of you.
Yeah. All right. So what's going on with you?
So he came in, he's a 47-year-old male that came in with pancreatitis, secondary to ETOH. He's home with his mom, lives with his mom. He's up at Live, he can get up by himself, he's pretty steady on his feet. He's got an IV in his left AC, dated for the 14th, as you can see. And that's got normal funding going at 125 an hour now. But I did give him, for 4 hours, I ran it for 500 cc's an hour, for 4 hours. So that's complete. His last dollar was on the 13th. His BTE is SEDs. He's MPO. He cannot have anything to eat or drink. He's been pretty compliant with that. No CBGs. He is on telly. He's been running sinus braiding. He's been down into the 30s. The doctor's aware of that. He said he don't want to be notified unless he's less than 35 or asymptomatic. And he has not been needed. We did walk in the house today. The doctor wanted us to walk in the house. He did that well. His vital signs have been Q6 hour, and they've been afebrile and very stable. We are doing a C-Word protocol on him every 6 hours, and he's been 0 for that. He does have an order that he can have an EKG if he needed for chest pain, but he hadn't complained of any chest pain from me, just some abdominal pain, and I did give him 2 milligrams of morphine for that.
What time?
That was around 11 o'clock this morning. I did send the urine down for drug screen.
Okay.
His history is pretty much, he's a smoker, like I said, ETOH abuse, has some history of GERD as well.
Okay.
Bradycardia, syncope. He has had stents placed, 2 stents placed. Has history of chest pain as well. Anything you want to add, Mr. McAllister?
I've had some diarrhea.
Had some diarrhea too?
Yeah.
When did that start?
About 20-25 minutes ago.
Oh, okay.
We'll add that.
We'll need to keep an eye on that, okay?
And he doesn't have Foley or CBGs.
Yeah, he's using the journal.
Okay.
CBGs, yes.
All right. Is that it?
That's it. Do you have any questions?
Join the scene.
Well, I enjoyed taking care of you today.
Thank you.
Janice is going to take real good care of you. So you have a good day, okay?
You too.
All the honeys looking sweet as queens. Look at them kicking with the mellow strokes. And all the fellas with the clean machines. Let's kick it with the mellow strokes. Mellow folks.
Happening. That's all the way. But I make such a
Mellow
business of the email and right. You make sure that you write. They always see their fault. Nobody ever, hardly ever, Then I had the Christmas tree.
Yeah.
My daughter brought the Christmas tree in, and the nurses would bring the other patients by my room to see the Christmas tree.
That's right.
Because I got out Christmas Eve.
Thank you very much for coming by and
I
telling
had
us
to
what
come
we're
see
doing.
you. I told Mary, man, let's go up to 50, 500 to see if they're still there.
Yeah.
How'd she come out with the baby?
She came out with almost a 13-pound baby.
Oh,
Yeah. She was huge.
That's more
She's
about
the
my
one who
daughter.
brought the Christmas tree.
Yep, her and the
yeah.
boyfriend.
Yeah, I remember.
I'd leave it to me down to the they should always get recognized.
So you know this is gonna be like on Universal TV, like.
Doesn't bother me at all. That's my fault.
You aren't playing with it, are you? Because you can get in big trouble if you don't know what you do.